Welcome to our live webcast, Novel Minimally Invasive Interventions, Decompressions, Spacers, and Endoscopic Options. Thank you for joining us tonight. My name is Rene Przkora. I'll be the moderator for this webinar, and I'm also a professor of anesthesiology and pain medicine at the University of Florida in Gainesville. And I'm joined by our speakers, Drs. Meroney, Chong and Dr. Sanjeev Kumar. And it's my pleasure to introduce our speakers. Dr. Meroney is an assistant professor at the University of Florida, Division of Pain Medicine. And Dr. Chong is a professor of physical medicine and rehabilitation and anesthesiology at the Case Western Reserve University School of Medicine. And he's also the program director there of the Pain Medicine Fellowship. And we'll be joined by Dr. Sanjeev Kumar. He is an associate professor at the University of Florida in Gainesville, anesthesiology and pain medicine. I would like to highlight the feature at the bottom of your screen, the Q&A bottom or button. Please use it to post any questions. We will go to the three presentations tonight, and we will answer the questions live at the end of all presentations, roughly around 8 p.m. Again, welcome to our tonight's webinar, and it's my pleasure to start the presentations with Dr. Matthew Meroney. Matt?
Good afternoon. So I will start by discussing minimally invasive lumbar decompression, also known as the mild procedure. So this is a minimally invasive approach to improve and treat spinal stenosis secondary to specifically ligamentum flavum hypertrophy. As you can see here, there's from left to right, there's a normal MRI on the left and a severe central canal stenotic area on the right. And you may see anywhere in between these cases. Specifically, lumbar spinal stenosis is incredibly common. About 20% of patients over 60 suffer from this. And again, one of the requirements to consider this procedure is ligamentum flavum hypertrophy. It's generally labeled as at least 2.5 millimeters thick, contributing to the stenosis. Frequently, you'll see it much thicker than that. Obviously, patient selection is incredibly important. These patients generally will present with signs of neurogenic claudication. That's specifically going to present with a combination of some combination of pain and or numbness, heaviness, paresthesias in the back, buttocks, and leg. Generally, this pain or discomfort will worsen when the patient stands and or walks. And specifically, they'll notice somewhat notable reproducible improvement in pain when they either sit or lean forward. So this is when you'll frequently ask the shopping cart sign, do you feel like you need to lean forward and put weight on your shopping cart? And frequently these patients that's the only way they'll be able to get around the grocery stores by doing that. Otherwise it'll be physically impossible because they'll have to stop and sit down in some cases every 50 feet. I think it's important to point out that to ask a little bit about timing, specifically because these patients will notice notable improvement with relatively quickly. It's not going to be over 30 minutes. It's going to be, they're going to notice a feeling of relief relatively quickly after sitting down or leaning forward. They might also notice improvement with the fetal position in sitting or laying in that bed. And generally these patients, they should have already failed conservative therapy. So physical therapies, epidural steroid injections, oral therapy, and so on. So obviously this is the axial cut of the MRI. And again, it's incredibly important for you to read your own MRIs because frequently the radiologists they're not gonna know exactly how to comment on if they are a good candidate for this procedure. The sagittal view is also very important. Here, you're going to rule out some patients if they have worse than grade 2 listhesis. If they have dynamic instability, which you may notice on FlexX, obviously if they have an infection in this area, or if they have post-surgical changes in this area that make it that may make them a non-candidate for various reasons. Those patients you likely wouldn't be starting with. So what are the advantages of this procedure? Well, obviously it's minimally invasive, that's in the name. These patients you can pretty much do under just local if you needed to. I've already done that, and it was obviously if it's a patient that can handle that type of, a stressful environment. I've had success with that myself. General anesthesia is definitely not required. And from a safety standpoint, statistically, it's considered just about as safe as an epidural steroid injection. We'll get into that a little bit more. Other considerations is that there's no implants as other procedures require, so infection risk is significantly reduced. And it's frequently you can treat multiple sites, as in bilateral sites at multiple levels, usually from one incision, because you have some elasticity of the skin site. So you can have one incision. Generally, it's less than a centimeter wide. So frequently, you don't even need a stitch. You can just use Dermabond or what your preference is. Post-op pain generally is considered mild to moderate, though they obviously will have some procedural discomfort at that site. And because we're not touching the disc, we're not, disrupting the annulus, there's a not significant severe post-op restrictions. So patients can get back to life relatively quickly. What are the disadvantages? Well, obviously there's fluoro, it's radiation exposure, which though it's limited, and it's minimally invasive. So you don't have the option of completely decompressing that interlaminar window, but that takes a lot more time anyway. So you do have, you're going to remove a portion, a few, milliliters of ligament, and generally that's enough to give some relief. From a safety standpoint, again, statistically, the MIDAS study showed about a 1.3% incidence of complications, and these were not severe. And I like always understanding, what does that mean? What complications do they have? Well, if you look at this, there was two reported issues. One was procedural pain, and one patient had what they rated as a procedural hemorrhage. So what did that require? It did not require inpatient therapy. The patient was still discharged. They just used some gel foam that controlled the bleed. The patient was sent home that day. So that's pretty much the worst thing that's been reported in these cases. So still, I feel that's pretty reasonable. It's not, these patients are not requiring admission. So the data, specifically, there's multiple randomized controlled trials, level 1 data, that show notable improvement in their pain, their ability to function, walk, and stand. And some of this data even shows that this has a durable effect up to 5 years. So this is ongoing, but there's been tens of thousands, over 30,000 of patients treated with this procedure, and very minimal side effects or complications. I'm not going to go over every study. This is the most recent study. It was actually published earlier in February, the MOTION study. It's a randomized controlled trial that is kind of headed by Cleveland Clinic and a few other facilities, which I like. I mean, all these cases or all these trials do have a little bit of support by the distributor of MILD, but this one, again, it was headed by Cleveland Clinic. And I'll just point out 3 very important statistics. So at the 1-year mark, patients were noted to have a 258% improvement in their walking tolerance test. So, if they could walk 5 minutes, now it's 25 minutes. And that, it's the difference between you going to the store or not. Some of the other studies have actually shown better than this. So this is just the most recent study. I've definitely talked to patients specifically that they're, before, one patient specifically, like they couldn't wash their car, their SUV or their camper. They had to sit down and rest every 2 minutes. It took them 30 attempts to do it. And after the MILD, they could do it after 1 attempt. So, obviously that's, not a full group of patients, but we've had success with it. Specifically, again, candidate-wise, if you look at on the left, only about 4% of these patients only had central canal stenosis. So by far the majority of them had lateral or pyramidal stenosis of some sort. So you don't have to nitpick to patients that only have that. It can benefit patients. But obviously, if the sole problem is lateral, you might want to consider a procedure that will focus more specifically in that area. And many of these patients, 71% of them, had multiple spinal comorbidities. So this wasn't the only problem they had, but they still had notable improvement in their situation. And of note, these patients specifically had about an 80% decrease in the requirement of subsequent lumbar spine intervention, whether that be, a fusion, something substantial. So, pretty relevant as well. So here is just the basics of the procedure. You do have a portal that you can stick your tools through at the surface of the patient. The second image is the bone rajour that has the ability to decompress or do small bites or laminotomy bites, which allows you to have access for the next tool, which is the tissue sculptor, which does a better job of removing softer tissue. And generally the goal is to remove about 2 cc's of tissue or so in that location. Usually it's 3 passes with which the tissue sculptor, and you'll notice improved range of motion and decreased ligament return while you're doing the surgery. Here's a basic anatomical view of a cadaver. So here you can see the lamina, which is in red, and the orange is where you can take bites of the bone rajour to gain access with the second tool, which would be the tissue sculptor, to remove the collagen, which is the ligament. You can see the ligament here, it's kind of yellow, but you want to avoid going past that, which obviously has important other nerve structures. This is a view you'll frequently see. You'll generally be taught to place an epidural needle and then inject some contrast, which will delineate the ligamentum flavum and allow you to kind of understand how deep or how aggressive you can be without accessing the epidural area. Though, as you can see, this dotted line, which is the VILL, the ventral interlaminar line, you can use that without contrast, and that generally is frequently a safe line as long as you don't pass that. And if you have suboptimal contrast spread, then you can use that to guide you anatomically. Here is it's an image of gaining access with a small incision. This is the trocar, which you'll use to access the interlaminar window on AP. And the next view is critical. You really want your tools relatively parallel to the lamina. So if this was shingled and therefore a much more elderly patient, you'll be able to access the superior and inferior lamina. If you aren't parallel, then it's going to be more difficult. You're going to have to go through more bone. This view shows the tissue or the bone rajour. You can see it taking bites of the lamina. Generally, you can take osteophytes out, and this allows you to gain access with the tissue sculptor, which takes the majority of the ligament, as you can see here. This is just an example. You're going to see a lot of different patients with different anatomy, hemilaminectomies, intrathecal pumps, hardware, synovial cysts, spondylolisthesis. It's generally not where you want to start, but in the right scenario, these all can be considered depending on how severe it is, or their problem is. And again, last slide. Generally in 24 hours, they have no restrictions and they can start doing physical therapy, and then you'll see them over the next few weeks. Generally it's 6 weeks. They frequently will note pretty significant relief. If they're going to respond, usually you'll know by then, but frequently before that. And that's the last of my slides.
Matthew, thank you very much for the presentation about the MILD, or the mild procedure. And I think that's a very good transition now to Chong Kim from Case Western University, and he will talk about interspinous spacers. Thank you.
All right. Good evening. So thank you for the introduction. Sorry about the little unmuting. So as I was introduced, my name is Chong Kim. I work at MetroHealth. Also have faculty appointment in case. Just for full disclosure, we'll only be discussing on-label use, but only thing relevant is that in the past I have participated in research regarding some of what we'll discuss, specifically Vertiflex here. Objectives, we'll just go over some general definitions and examples, the indication and patient selection, as well as a brief overview of the technique, and then do a quick evidence review. So first question is, what is it? What is an interspinous spacer? So if you actually just think about it, it makes sense, but it's also known as minimally invasive interspinous process devices, interspinous distraction devices, as well as interspinous stabilizers. But if you just think about the two things, it's something that basically takes up space between the spinous process, and it's meant to mechanically inhibit extension of your lumbar spine. There's numerous devices available at this time. You can look it up. In the past, X-Stop was one of the bigger ones, Coflex, especially for the pain folks. A lot of us have basically kind of focused on this Pyrin by Vertiflex, which is the two circle right here. That's what we're going to focus on for the rest of the talk. All the information here is provided by the company, which is now owned by Boston Scientific. The indications. This is straight from their brochure. It's indicated for patients with neurogenic intermittent claudication secondary to diagnosis of moderate degenerative lumbar spinal stenosis. As previously discussed in the talk before, it's for people who basically get relief when they're in flexion or sitting, and then it worsens when they stand, whether it's in their butt, legs, groin, so forth. They should have tried non-operative conservative treatment for at least 6 months, or they should have been suffering from this for at least 6 months. You can do up to 2 levels from L1 to L5, and then the diagnosis should be confirmed by some kind of imaging, and ideology is not that relevant as long as it's still a diagnosis of neurogenic intermittent claudication. They have this little fine print. If you blow it up, it basically covers what we just talked about. In terms of clinical symptoms, again, this was discussed previously. It's patients who notice it when they're in extension, standing, walking, whether it's heaviness, tingling, pain, back, butt, down the legs, any combination. It's the shopping cart sign. It's much improved when they sit. And then you guys all know how to ask these questions in terms of diagnosing lumbar spinal stenosis with neurogenic claudication. Contraindications, obviously, if they're allergic to the material used, any kind of instability, any kind of spondylolisthesis greater than grade 1, any ankylosing segment or any kind of fractures, scoliosis with Cobb angle greater than 10 degrees, any previous history of decompression at the level that you're looking for. They say morbid obesity, a BMI of 40, but again, it all depends where you practice, where you see that BMI. So there's maybe a little flexibility, but in terms of the actual contraindications published by the company, it's 40 BMI. Any kind of cauda equina, any kind of severe osteoporosis. Again, if their spine's not able to tolerate this, they're not a good candidate. Then any kind of systemic infection that you're aware of, or local infection where you're targeting the implant. In terms of technique, it's really important that you actually get them in a flex position. Typically, I use either a Wilson flame or a Jackson table. You need fluoroscopy, which means you need to be mindful of the radiation. Most of the newer interventions, or a lot of the minimally invasive surgical interventions, tend to use radiation, and so we caution you, be mindful that there may be more radiation, especially because of whether it's lateral views, oblique views in other procedures, or contralateral oblique, so forth, that there may be more radiation than typical procedures. In terms of the technique, these are the commonly used tools for Vertiflex. The first thing is the introducer. Basically, it's as close of an orthopedic procedure as we're probably going to do, where there's a lot of hammering. Using the C-arm, you visualize the interspinous space that you wanted to target. Obviously, you have to do some preparation in advance in terms of imaging as well as patient education. After a little incision, your goal is to place this introducer between the spinous process such that you are getting to the depth that you want. There's a lot of PA and lateral views. There's hammering. And then once you get the first introducer seated, you take the second component, which is the expander. You put it over the initial introducer after you take the plastic device off, and then you hammer this down. And then in the past, there were several different components. Now they've kind of combined into one. You only hammer on the plastic components. And then on the lateral view, advance it approximately half to 2/3 depth, or until you get a pretty good seating. Once you get that seated, you actually have to size out what kind of spacer you're going to place. You basically introduce this component, squeeze. It tells you whether it's 10 millimeters, 12 millimeters, 14 millimeters, the size of the spacer you'll actually be putting in. This kind of shows you a lateral view of that. And then once you've done the sizing, you have to pick out the actual spacer you're going to use, connect it, test it out before you actually place it in. The last device is what you use to connect it. You advance it back into the area you've checked. You use this new device, the last piece, where you basically open the spacer up. You turn it. There's some general resistance. If it's too much resistance, either you're offline or you didn't clean out the space enough. This X-ray shows you how it opens up on a lateral view. Once you get this relatively seated, you actually take out the device that cranks it open, and you can tap it into place. The goal is to make sure you get PA lateral view for confirmation, so that you see the spacer be deployed within the spinous process and flush within the interspinous space. At the end, I typically use a couple sutures, 1 or 2. One thing I do advise the patients is they do have some bleeding because you did go between the spinous process, interspinous ligaments, so forth. Especially the first 12 hours when they go home, it's not uncommon that they will actually have quite a bit of bleeding. They have to change the dressing out, and usually by the morning it completely stops. Last thing we're going to go over is the evidence. It was initially introduced in 2011. It was published in Clinical Interventions in Aging. Again, not a big impact factor journal, but what it showed was that they were looking at the safety and effectiveness of this novel minimally invasive interspinous spacer in modern lumbar spinal stenosis. And what they found was that it can be effective in the right patient. Again, their goal was to just show that this was worth studying. Their big study got published in Spine, a much more respectable and established journal, in 2015. They published 2-year results from a randomized controlled FDA IDE pivotal trial. What they did was study patients, again, with moderate lumbar spinal stenosis with intermittent neurogenic claudication, and they compared it to a controlled spacer, which is the next stop that had been on the market for some time. Results, they looked at 391 randomized patients, about 190 to 200. What they basically found was that it was non-inferior to a conventional device that had been used at 2 years. More recently, there's more updated data, 2017. They showed 5-year durability results. Basically showed that at 5 years, about 84% of patients demonstrated clinical success on their standards. They looked at symptom severity, physical function, satisfaction. They looked at VAS and back and leg pain, ODI, as well as other measures. Just keep in mind, any of these summaries, you need to do your due diligence and read the papers yourself. It may reinforce what you believe in, or at least get you to be much more critical of the evidence that exists. 2018, some summary. They also start looking at other components. It's a big thing the past several years that not only should we get improvements of pain scores, function, anything that decreases opioid use is considered successful. Here's a year 1, 2, 3, and 4, the reduction in opioids. And finally, most recent one was in 2019, where they basically started publishing a registry of real-world data. Because keep in mind, anything that's done in a clinical trial may not reflect exactly the patient population that you have or you will have. Nonetheless, they had approximately 190 patients, and they looked at different types of stenosis, and they found, again, improvements at 6 and 12 months in terms of back pain as well as neck pain. So summary, real quick, again, it's not be-all end-all for lumbar spinal stenosis neurogenic claudication, but it's definitely something worth having in your tool bag. Utilize it with other techniques. Depending on where you train, the basic skills you set up, you learn will allow you to do this. Just again, I remind you to review the data on your own, and then obviously make sure patient selection is key, and then test it out for yourself.
Well, thank you for the presentation. So those was about the interspinous spacers, and it's my pleasure to introduce Dr. Kumar from the University of Florida, and he will provide the last presentation for tonight's webinar, and is about endoscopic spine procedures, full endoscopic spine surgeries. Sanjeev, welcome to the stage, and it's yours.
Good evening, everyone. So this is regarding endoscopic spine surgeries and other endoscopic procedures. So I have no disclosures. I'm not affiliated with any pharmaceutical or device companies. So endoscopic spine surgery is a form of the least invasive form of spine surgery. So this is a true spine surgery. So every other minimally invasive techniques are indirect decompression, where you actually can't see it. You have to use fluoroscopy. This is the only approach where actually you can see inside the spinal canal. You can see the dura, you can see the nerve roots, you can see the facet joints, you can see any abnormal structures inside the spinal canal, and you can do whatever it takes to get rid of the pathology. So a brief history of spine endoscopy. So at the turn of century, like in 1909, Cross and Oppenheim described the first discectomy. And the initial surgeries that were done at the turn of century were pretty traumatic. Like Dr. Mixter and Barr in 1934 published a case series of lumbar discectomies. And they did a full laminectomy, and they did transdural access to the disc. So a lot of these patients, even though they had decompression for the nerve roots, but they had collateral damage in the form of unstable spine due to leaks and a lot of post-op pain. So there's always this idea to find minimally invasive surgical approaches. In the 1970s, microscopic surgery developed in US, and it was refined with better instruments and visuals. By 1990, it became the gold standard for spine surgery. Parallel to microscopic surgery, percutaneous and endoscopic approaches were being developed in Asia, especially in Japan. In 1975, Hijikata, he performed the first posterolateral disc access with tubes and trephines under fluoroscopy. And he also used pituitary rongears for percutaneous nucleotomy. He published his findings in an obscure Japanese journal, and it was not discovered almost till 10 years later. Parvis Cambin, who has been credited with finding the Cambin's triangle, he refined the technique of percutaneous discectomy, and he went through the Cambin's triangle. Again, 1989, Schreiber, Srijawa, and Liu. So they actually got the idea of actually using an endoscope to visualize what they're removing from the nucleus. They called this technique discoscopy. So the Germans came in the picture in 1989, and Meyer and Brock refined instruments for the endoscope, and also the instrument for the rongears, and they called their technique Berlin technique. In 1996, Hal Matthews in Germany and Tony Young in the US, they had more, they described more lateral access for transfemoral endoscopy. And Tony Young also used continuous irrigation technique, and he has been credited with the inside-out approach for spine endoscopy. In 2000, Hugland in Germany, he described the outside-in approach. And so 2001 was a game changer for endoscopic surgeries. Sebastian Rutten, he is considered the father of modern spine endoscopy. And he described the interlaminar approach, and he used arthroscopic techniques. He used high-speed drills, lasers, burrs, and advanced instruments to take down any pathology of the spine. So, so basically, we have about 20 years of history of modern spine endoscopy. And about 6-7 years ago, a bipolar radiofrequency electrocautery came in, which was another game changer. Previous to this, we were using lasers for spine endoscopy, and the term laser spine surgery was quite common. Since the bipolar radiofrequency electrocautery came in, the surgeries have become much more precise, much less invasive, and also very successful. Laser was non-forgiving, and bipolar radiofrequency electrocautery is much more forgiving and much more precise. So typically we are viewed as physicians who can mask the problem, or we can manage chronic pain. But given a choice, will you try to fix the problem or mask it? So a lot of spine pathologies like large disc herniations, large facet cyst, failed back syndrome, epidural fibrosis, large bulky degenerated facets, disc osteophytes, Bertolotti pseudojoint, they can cause significant pain and nerve impingement. And sometimes we keep doing these injection procedures, and the patient gets few days to few weeks or sometimes few months relief, but then the pain comes back again. And we always wish, can we do something to fix it? Open surgical approaches are much more traumatic, and they can cause instability of the spine. But nowadays, there are options where we can actually relieve these symptoms and actually fix the problem using minimally invasive surgical approaches. Severe lumbar spinal stenosis can cause compression and edema of chorda equina nerve roots. And a lot of times when we see that on the MRI, we know that physical therapy is certainly not going to work. And our injections, our caudals, our transframals, they might give them few weeks at the most, maybe few months, but that's it. And eventually the symptoms will keep coming back. So we can have mild and vertiflex for mild to moderate stenosis, but for severe stenosis, there are not much options left. The surgical options is the only thing that can relieve the stenosis for these patients. And traditional surgeries is much more traumatic and can cause much more instability of the spine. So conservative treatments are not realistic at times, as patients have severe pain and no disability, which likely won't respond to any therapy or injections in short to medium term. So endoscopic surgical techniques can treat any single level or adjacent level pathologies anywhere in the spine. So one of the advantages that we have with endoscopic surgeries is we can seal the annular rent, and we can harden the nucleus using bipolar radiofrequency electrocautery. This prevents reherniation. This is unique to endoscopy. There are several other unique things that I will describe later in my talk. So don't settle for less. You know, like no one likes to hear that they need to learn to live with weakness, numbness, paresthesias. So we can sometimes achieve pain relief by our injections. The spinal cord stimulators can also help do that. But the recovery of nerve function is a goal which no one else, no other technique can achieve unless we can actually relieve compression of the nerve roots. And the plasticity of nerves is well documented. The earlier thought process that once the nerve is damaged, it doesn't recover, so you have to live with it. It's not true anymore. We have shown that, we have published data that once we do the decompression, the nerve bounces back. The full function comes back. So the first question I get often is, can I get trained in endoscopic spine surgery? So at University of Florida, endoscopic spine surgery is performed only by pain physicians, with pain medicine fellows participation and training. So we are starting our first in the country likely endoscopic spine fellowship at UF from July 1st, 22. This will be an extra year with certification of pain medicine physicians. Applications are welcome from fellows with stellar surgical skills and understanding of spine anatomy. To be skillful with endoscopy, you have to have mastery of understanding of interpreting spine MRIs and CT images. To have a 3D perspective, you should understand the spinal architecture and stability, and you need to know the indications as well as the limitations of spine endoscopy. So very few spine fellowships run by neurosurgery incorporate spine endoscopy in their training. So there's not much formal training given in neurosurgery about spine endoscopy. There is some cadaver lab sponsored by the industry that gives some exposure. There's a long and steep learning curve, and it needs a master trainer initially. And one of the other things that lately has been going on is our surgeons, colleagues are not happy with non-surgeons doing surgeries. So having an extra year, like a extra endoscopic spine fellowship year, which is the 6th year, this counters the argument that we have lack of training. And the first thing, I teach, my fellows is how to identify the person who needs surgery, and you have to learn to take care of your own complication. Like if there's a dural tear, you need to learn to take care of the dural tears. So this is why an extra year is so important, that that makes you kind of at par with the spine surgery. So we have several firsts at UF in our endoscopic spine surgery program. We have reported our first case series of fast-assist decompression by pain medicine physicians. This is the first series by a pain physician. We've also reported pain outcomes after endoscopic surgery at an academic pain medicine program. We've also reported endoscopic recession of ossified ligamentum flavum by a pain physician. This is the first, as well as decompression of severe spinal canal stenosis due to ossification of the ligamentum flavum. And we have also reported our first case series of Bertolotti pseudojoint endoscopic resection with excellent outcomes. So this is a flow chart from neurosurgeon Dr. Albert Talafian. He was the person who introduced me to endoscopic spine surgery in 2012. And he's a neurosurgeon and chief of minimally invasive spine surgery in Rhode Island Hospital at Brown University in Rhode Island. And as per his flow chart, you can see like he goes through for neurosurgeons how to get trained in spine endoscopy. So you see he goes through, you have to attend professional society meetings and courses, you have to practice cadaver workshops, then you have to identify a mentor and observe live surgeries, and then you have to employ diagnostic and prognostic procedures, like practice selective blocks, discograms, and epidurograms. Now, this is where we come in play because we already know how to do this. So we can diagnose first and then choose our surgical patients. And again, this holds true that you start with simple cases like far lateral herniated nucleus pulposus, then you can expand to paracentral and central herniated nucleus pulposus, and then you can progress to foraminal and lateral recess stenosis, and then you can analyze outcomes and contribute, and then present and publish your outcomes, and then you can teach others and become a mentor. This flow chart is for neurosurgeons and ortho spine surgeons. So, endoscopic spine surgery, the least invasive approach and the best, and it has the best visualization for spine pathologies. There's an eye inside the spine. Like this is a picture for open spine surgery. From the eye level, you have to resect, you have to cut tissues, and you have to open a big section of the skin and muscles and cut a large section of the spine to actually visualize. When microscope came, there was an advantage that you can have a magnified image, but you still have to resect muscles and bones to actually see inside. You have a nice magnified view, but you still have to resect a lot of your native tissues. So the endoscope, you can see it has a light source, it has camera. Once you put the working tube inside, you actually go through the interlaminar window or through the foramen, and you can actually get inside, get very close to the dura, or get very close to the pathology. So there is a magnified image. So the image is magnified 20 times. And with continuous irrigation, this image is very crystal clear. So that's an advantage of endoscopic spine surgery over other forms of surgery. So how do you plan for starting out endoscopic spine surgery in your practice if you are a pain physician? Well, you have to reach out to your neurosurgeons and ortho spine surgeons in your institution to have a frank conversation, because certainly you're kind of encroaching on their turf. And you have to identify any barriers and strategies how to overcome those barriers. And certainly you have to shadow a mentor and observe live surgeries. Remember, it's a very steep learning curve. You have to attend meetings and cadaver workshops. NAS, North American Spine Society, conducts regular courses and cadaver workshops for spine endoscopy. Of course, then you have to get credentialing. For that, you have to certify or prove that you can do these cases in your institution, and you have to get approval for your malpractice insurance carrier. And then you can start with endoscopic rhizotomy. Endoscopic rhizotomy involves putting those same instruments outside the spinal canal at the junction of the SAP and the transverse process. And this is safe. You're not violating the spinal canal, and you get used to holding the scope and using the instruments. So it's a good place to start. And that way you can learn how to manipulate those equipments. And then once you have done a few of these cases, I would say about 20, 25 of these, you get a pretty good idea how to hold those equipments. And then you can start off with transfemoral endoscopic surgeries. You can start from foraminal herniation because the herniation is right in the foramen, it's looking at you. And then you can progress to paracentral herniation, central herniations. Then interlaminar L5S from disc herniation, you have to do at least 10 before you can progress to higher levels, because going to higher levels involves bone resection, which involves birds and drills. And then you can get into foraminal stenosis, lateral recess stenosis, central canal stenosis in that order. And then further you can progress to thoracic stenosis decompression and posterior cervical decompression. So this is the ascending curve of skill sets that comes from practice. And this is how people progress in their practice for endoscopic spine surgeries. So I have some few MRI images. We get several patients we have done surgeries. So their MRIs before and after. So this is a right L4-5 paracentral herniation. It's a pretty easy case to start off with using the transfemoral approach. And this was done by one of my ex-fellows. So he was doing pretty solo, he was flying solo. And this is the pre-op MRIs, axial cut and sagittal section. And after 3 months, when the patient come back for follow-up, this is a post-op. Patient was 100% better, radicular pain was gone. And he was having full functionality in his lower extremity on the right side. It's a clean cut. You see, this is the pathology has been completely removed. So this is the fluoroscopic view where you put the needle first, and the guide wire goes over the needle, and serial dilators go over the guide wire. And then you put your working tube. Through the working tube, put scope. And this is the picture from the scope. And it's very hard to identify the structures when you first see them. This is why you have to observe a lot of these cases to identify those structures. And then you have to have somebody proctor you when you start doing these cases. This is a large L5S1 disc herniation. This is the pre-op right-sided L5S1 disc herniation. Again, all these images, MRIs, are from our patient, from our institution. They have been de-identified, and a consent has been taken from these patients to present the images in this meeting. So this is a large right-sided paracentral disc herniation impinging the S1 and S2 nerve roots, the axial cut and the sagittal cut, and this is after the endoscopic surgery. You can see it's a clean cut. You don't see any muscles being cut. You see the lamina intact. The only thing you see is a ligamentum flavum dissection, which allowed us to put our scope inside the spinal canal. And you can see the nerve roots are free from the disc. And you can see the sagittal section. It looks like clean cut. This is a clean cut surgery. It doesn't have much collateral damage. And this is the same fluoroscopy pictures. Of course, we initially used fluoroscopy to put our instruments in, but that is just for the first few seconds maybe. Once we get access, there's no need of fluoroscopy. We just use our scope tower to visualize our spinal canal and our instruments going inside. This is the AP view and this is the lateral view. So we have done several cases for failed back syndrome. And this is one case where there was epidural fibrosis. This patient had a foot drop from previous hemilaminectomy at L4-5. If you can see, there's scar tissue surrounding the traversing L5 nerve root on the left side. So this patient had foot drop for almost 8 years and weakness of the left lower extremity, and nothing was working. So this is a transfemoral left-sided L4-5 approach. You can see the scope going in, the instruments going in. This is just fluoroscopic images of the surgery. And so like this was a pretty scarred nerve root L5. It's like it's peeling the onion. You have to be close, but not too close. So you can see the L5 nerve root was totally encased in scar tissue. And after all our cleaning, this nerve looks like this. This is all still scar tissue, but we were able to free up the nerve, and the patient was able to move the foot immediately in the post-op period. She actually walked out. She came in a wheelchair. She actually walked out after the surgery. So one of the other advantages of this is we can actually get to axillary herniations. If you know, the herniations are two kinds: the axillary herniation and the shoulder herniation. And shoulder herniations pushes the traversing nerve medial, so it's very easy to access this, the shoulder herniations because you're lateral to the nerve root. This is the S1 nerve root. This is the dura. So this is the axilla. So sometimes you can actually access the axillary herniation directly going inside, putting instruments and accessing directly those axillary herniations. And this is the rent where the disc came out. And this is now the nerve roots and the dura looks clean. So we can, after we're done, we can actually access the hidden zone by lifting the nerve and lifting the dura. We can look inside, look underneath those nerve roots and the dura and see if there's anything else left. This is hard to achieve by traditional surgical approaches. With our scope, we can actually use our scope as an instrument and lift the nerve root and the dura up, and we can look underneath the nerve root and the dura. It's pretty nice to do that, and you can actually sweep underneath the ventral aspect of the nerve root and the dura to make sure all the pathology is gone. So I talked about getting good at interpretation of MRI images. So a lot of times, radiologists miss some findings, and this is an example where a patient came to me for a second opinion. This patient had a large central paracentral herniation at L5S1, and this patient was ready to have a microscopic surgery by a neurosurgeon at an outside institution. She came to me for a second opinion. I looked at her MRI, and she had more left-sided symptoms, so the surgeon planned for a left-sided L5S1 microscopic discectomy for her. And I looked at her MRI and told her that that's not a good strategy. And the reason being, I'll show that later on the next slides. But I told her that's not a good strategy, and I can come from the right side and still get the disc out and get to left-sided symptoms better. So she did that. This is the pre-op large herniation. She predominantly a left-sided symptom. This is the axial cut, this is the sagittal cut, and this is post-op. Again, this clean, everything has been resected beautifully. There's no damage to the lamina or to the muscles. Everything is still intact. So you have to look closely at your images. So this lady had a common nerve sheath from the L5 nerve and the S1 nerve. You can see this is the L5 nerve exiting an S1 traversing nerve. They share a common sheath. So had the surgery been done from the left side, it would have stretched the S1 nerve root, traversing nerve root, and could have caused injury under general anesthesia. We typically do the surgeries under general anesthesia with neuromonitoring, using EMG for lumbar spine. But still, sometimes we can still cause injury by retraction of the nerve roots. And this is another one of our patients, large L4-5 central paracentral disc herniation, almost filling up the spinal canal, causing severe stenosis. This is a pre-op. You can see this on the sagittal view. And this is our post-op. You can see it's clean surgery again. This has been nicely resected, and the patient did 100% better. The beauty of this surgery is outpatient surgical procedure. Patient goes home the same day, and they can actually start feeling immediate relief when they wake up in the PACU. One of the most common patients we encounter is elderly patient with severe stenosis in the spinal canal, lumbar spine. So our endoscopic decompression of severe stenosis is a pretty safe outpatient surgical procedure. So in this patient, you can see this is multi-level stenosis, and it's pretty common to see these cases in our practice. But you have like L3, 4, L4, 5, L5S on all levels stenotic, and thick ligamentum flavum, hypertrophic facet joint, bulging disc, the trifecta, and you can see the edema of the nerve roots there. I don't know if you can appreciate the edema of the nerve roots, but just about the compression, it's like the nerves are being compressed and they are being choked. So these nerve roots have actually lymphatics on them, and you can actually see the color becoming less darker just above the compression. This is edema of the nerve roots. So this is the pre-op edema picture, and this is the post-op. After the last two pictures are post-op, you can see 2-level endoscopic decompression has been done, and the edema disappears, or edema has decreased, and the patient is doing really well after surgery. So one of the things that I like to describe is a lot of times, we are kind of bombarded by our reps who try to come in and give you talks and lunches and dinners. And one of the more common reason for using a spinal cord stimulator is CRPS, right? So sometimes just to get approval for CRPS, people make up the diagnosis of CRPS. Approval for spinal cord stimulator, people make up the diagnosis of CRPS. But if you look closely, sometimes you can find evidence of nerve irritation and compression of the spinal nerve roots by physical exam, by looking at MRI, and that is potentially curable. Like, given a choice, would you be masking the symptom or fixing the problem? So, what happens is for the past, I'd say 20, 25 years, we have stopped thinking outside the box. We think, oh, it's a foot pain. Oh, let me do a DRG at L5 and S1. Oh, it's a knee pain. Let me put a DRG at L3 and L4. Or it's a failed back. It has to be a spinal cord stimulator. A lot of these failed back syndromes are actually adjacent segment stenosis cases. If you look closely at the MRI, and those are potentially fixable. A surgeon can extend the fusion for those cases, but that's a big surgery. But your minimally invasive surgical approach can do an outpatient fixing of the stenosis for those cases. So worldwide endoscopic spine surgery is the preferred form of treatment for spine pathologies, which is a simple spine. Remember, simple spine, if the spine is complex, where there's advanced degeneration, scoliosis, or listhesis, endoscopic spine surgery is not the choice. You have to have open spine surgery or bigger form of surgery. But for simple spine, endoscopic spine surgery is the preferred form of treatment for spine pathologies. So it has been a slow adoption in the US due to focus on high dollar value surgeries and insurance limitations. So since 2016, they said you can only use CPT code 62380, which wasn't paying much. So they realized their mistake, and then AMA revised their definition. So a lot of these traditional surgeries and microsurgical codes have the word endoscopic assisted added since 2021. So like a 6303 is one of the most common codes used for hemilaminectomies or microscopic surgeries. And now the word endoscopic is added. So now we can use traditional spine surgery codes for those and get reimbursed for our service. So there are a lot of benefits of endoscopic spine surgery over traditional surgeries. I did briefly touch them before, but just to enumerate again, there's preservation of bones, muscles, and other soft tissues, and spinal architecture is almost unchanged after spine endoscopy. So even with grade 1 listhesia, sometimes grade 2 listhesia, you're not causing any further worsening of those listhesias. But you have to assess. You have to get imaging before and after flexion extension films to see whether the person is an appropriate candidate for those surgeries or not. So there's almost none or very minimal scar tissue. Recovery is very quick. This outpatient surgery, and some can be done in the local and MAC. And spine endoscopy does not burn any bridges for traditional surgery. So if your surgery fails, you still have the option of traditional open surgery. So the benefit of this, what I found in so many cases I've done, is old herniations with adhesions. Like, this is very classic case where traditional surgery can cause dural rent. The benefit of spine endoscopy is because of continuous irrigation. When you're just entering the ventral part of the flavum, you can increase the irrigation pressure, and this pushes the dura down and decreases the chance of dural rents. And we have freed up so many old herniations causing adhesions for the nerve roots and dura that, and we have seen that, like, physically, we have seen the nerve, which is red and angry, becomes pink and healthy, like even under our eyes, so right under our eyes. So the dogma of all spine surgeries are bad doesn't hold true with endoscopy. So earlier interventions can prevent chronic pain and future degeneration and stenosis. The aggressive surgeries of the past, they used to do a lot of disc resection, and that led to more degenerative changes as the spine ages. But we only focus on taking out the pathology and leaving the rest of the structures intact. So endoscopic spine surgery, should be preferred over, like sometimes, we have been wasting time by doing these injections. But for some fixable pathologies, endoscopic spine surgery should be selected rather than having the patient go through chronic pain and dysfunction. So as I said before, endoscopy is not for unstable spine or complex spine, so choose appropriately. There are new approaches like biportal approaches and endolift, which is endoscopic assisted lumbar fusion. So is here, and so the horizons has been expanding for endoscopic spine surgery, and now people are doing cervical spine, thoracic spine, any level of the spine surgeries has been done. Thank you.
All right, thank you very much for your presentation, Sanjeev. Those were some excellent images, I think, and also before and after, so you can see you can make a difference. And I think we have concluded the 3 presentations, so we are open for our Q&A session to answer the questions from the audience. And again, for the audience, please feel free to post your questions using the Q&A feature. Don't feel embarrassed for any questions you have. You're here to learn, and I think we have the experts on the call tonight. And I think I'll start off with the first 2 questions because they so go together. And the first question is, what advantages do you find comparing mild versus vertiflex? And then regarding mild and vertiflex, what clinical/imaging clues do you use to determine what procedure is better for each patient? Who wants to take that on? It's Dr. Meroney or Dr. Kim?
Well, maybe we'll touch on it, but I think it's important to note from a mild standpoint that you are limited to some degree from a surgical standpoint, that you're going to be, more or less addressing or debulking the ligamentum flavum more centrally. Obviously, you can, once you get familiar with the procedure, you'll have, you likely can interact with some of the more lateral flavum, but again, like if there's a lot of pyramidal stenosis, lateral recess stenosis, if you feel like that's the worst of it, then you're going to be limited to what you can address. It's going to be more central and the amount. So I think that's the benefit of, so the positive of the mild is, again, you're not adding any hardware, you're not affecting the interlaminar window for future procedures. Infection risk is less, you can treat multiple levels with less consequences. And obviously, Dr. Chim comment on the vertiflex, but I mean, I think the benefit of the vertiflex is you have more impact, central lateral recess, pyramidal. You can treat you're kind of indirectly treating those areas. And so therefore you'll have more success if it's more lateral. And obviously you can't really decompress. You can't put a vertiflex in each and every level. You're kind of limited to those things from a few other standpoints, like you mentioned, Cobb ankle. I don't know. I don't want to speak for you, Dr. Chim. I don't know if you want to, you have anything you want to throw in there from your standpoint.
No, I think you covered it. I think it's just I think the ideology is the first thing, and then obviously the comorbidities that go with it. And ultimately, it's your preference and what you are comfortable doing that you think is best for the patient. So the L5S1 is a no-brainer because you can't do that with the Vertiflex. There's no spinous process. So you're stuck with L1 and L5. But realistically, it's ideal you have both skill sets, and then the imaging as well as the ideology really does dictate what you offer.
Right, a few things I can weigh in. I agree with the speakers and my colleagues, and it's like on the interspinous spacer, you have an implant. In each of those interventions, there are certain comorbidities, where you are advised to may not proceed. So you may have to weigh risk benefits. Some colleagues say, if you have an implant, it is an implant, it may interfere with any additional approaches. You have to keep that in mind. It also depends a little bit on your training level or what you have been trained to use first in your practice. I think we can move along to the next question, and that's, I think, let's see, we answered that. Advantages, mild versus Vertiflex, I think we answered that. And then the next one is also addressing mild. For example, does the ligamentum flavum sort of grow back, recur? Who wants to weigh in on that?
I have seen it actually. So again, it's a small sample size, but where we've practiced, we participate in the -1 and 2 studies. So initially, we did this probably 8-9 years ago to start it. There's a handful of patients where they got really good relief because we remember the patients because they did so well, did not come back for any needs, and all of a sudden came back with symptomatic, got re-imaging, and we're like, oh, this is back. And there's a patient I recall, we've actually went back in afterwards with the mild, and they became significantly improved again, and we haven't seen them back. So it's a small sample size. It's one person anecdotal comment, but I have seen it.
Dr. Kim, did you see any difference in MRIs after your first mild?
Well, so keep in mind, after the first mild, we didn't get a subsequent MRI. Okay, they were just doing better, so we just let them be. When they came back, it was symptomatic again. So that you're correct.
Probably natural progression of stenosis. So when I get MRIs, the disc doesn't grow back because I dissect the whole for stenosis. I take down the entire flame. I actually dissect the whole flame on both sides, and it doesn't grow back. So
yeah, I would agree. We have some minimally invasive neurosurgeons who we actually use for patients who are mild candidates now at this point because of the resources. But it's one of those skill sets I think it's good to have, but I think the more options you have as well as colleagues you have, better off. Because I think one thing we forgot to mention, at least I did, anytime before I would put in a spacer, I always get a surgical opinion to say they're non-surgical at this point. That's how I practice, because in case I put the spacer and they're still symptomatic, I need somebody to go back in and remove that and take everything else. So I always get a surgical opinion where for mild, I don't necessarily need a surgical opinion, at least to intervene, in my opinion, because I think you're doing minimally invasive. You're just debulking components that are not really that invasive, in my opinion. But again, I think the skill set as well as the colleagues you have really does make the practice much more robust.
Yeah, and I agree. I've taken a few spacers out from my patients who progress in the stenosis and from other referrals. And it's not easy to take it out. Let me tell you that. It's pretty tough to take those spacers once you get scarred in. But but we can take it out though, yes. But it's been there for a couple of years to get scarred in. But we have taken few spacers out of our own patient and for referrals for us. Yes, we do that. We do that on our own by ourselves. Yeah, thank you.
I know you participate in some of the studies. Can you speculate, let's say, the post-op MRI after a mild procedure? What do you see? Not say if they become symptomatic again. Do you see a major difference? Let's say, is there a concern you're going to resect too much? What is your experience talking about the imaging studies?
Well, even the people who devised mild, they said MRI, you can't see much on the MRIs after mild.
Right. Chong, what do you see on your patients?
From my standpoint, I don't think it's I think the epiduragram changes as we guys see it when you do it, and you're like, wow, that's an improvement. But from the few that we've seen subsequent imaging on, I did question how much we're actually debulking of the posterior components, because to me it's not that significant. Although we dig up quite a bit on the table, I agree. Some of the imaging I don't really notice a whole lot, but their symptoms have improved enough.
Yeah, no, I do agree. You see the epiduragram while you're doing it, and then you have the clinical assessment, and also it means that the tissue resect may changes the call it the flexibility now of the ligamentum. So I do agree. I think one other aspect I like to mention is what you both brought up. You know, it's sort of the collegiality. You know, you want to talk to your spine surgeons or their colleagues, for credentialing, referral, also safety aspects. So you have sort of a backup and vice versa. And you know that you review the cases with them, so you decide which one is the best appropriate. So I think if you're thinking about, for the fellows on the call, setting up your practice, or when you come out of fellowship and you want to implement, or you want to start using some of the newer techniques, I think that's the best way, I think, to go. You know, and again, it's collegial. And if you convince your colleagues, and let's be fair, as Dr. Kumar also said, you know, you're not burning any bridges. Let's be fair, you're not taking away. And, you know, if you can show your outcomes, I think that's the best way to go. Now, I'll go back to some of the questions. And there's one question I think is in the chat box. And the question is probably for Dr. Kumar. I would say, has there been any reports of blindness from increased interspinal pressure from irrigation during endoscopic spine surgery?
So I can speak about myself. I've done a lot of these surgeries, and the only time I increase the irrigation pressure is when I'm about to puncture the flavum and when there's bleeding. The rest of the times I keep the irrigation pressure to a bare minimum, like 15-20 PSI, and that doesn't cause much of an increase in the pressure in the spinal canal. So, but yes, so you save those high pressure times at critical junctions where, you know, when you're entering the actual spinal canal by going through the flavum, and second, when there's actual bleeding inside. So to control the bleeding, you just increase the irrigation pump pressure, and then you have a clear field again. And then you can identify those bleeders and then zap them or ligate them, and that's it. So I'm not aware of any blindness, so to speak, for that.
All right, thank you for answering that. We're going back to the mild and vertiflex. There's a very good question, especially as our patient population are older and they have the comorbidities most likely requiring anticoagulation. So do we consider mild/vertiflex high or intermediate risk in terms of ASRA anticoagulation guidelines? Who wants to take that on? And I guess it may vary also depending a little bit on the practice. Chong, you want to go ahead?
I consider high. I think it's better to overestimate the risk than underestimate. So I consider high.
Yeah.
For me, I've put a lot of vertiflexes in. I don't stop any anticoagulant. The INR could be 5, I can still do it because we're not violating the spinal canal. As long as posterior spinal canal, everything else is compressible. I don't stop any anticoagulation or any antiplatelet agent for vertiflex.
I think those are again two experts answering. I'm more conservative. Both points I think are valid. Again, it's your comfort level. What you see, you know, some also argue, you know, if you're on anticoagulation, remember there's a reason you're on it. So if you take patients off anticoagulation, we're exposing them to some other risk, for example, an MI or a stroke. But again, if you go out in practice, you may want to follow for example, the ASRA guidelines. They're very good. They're reviewed by experts frequently, and that's something I think as a guidance you should use in your clinical practice, especially I would say at the beginning. So those are my few cents. I think we have one question left in the Q&A box. And I think, Dr. Kumar, I think you can answer that. Which endoscopic device manufacturer are you using?
Yeah, we're using Eloquence. So there are typically 3 companies, Joymax, Wolf, Richard Wolf system, and Eloquence in the US, and the other Korean companies who are trying to make their way in, like Endospine, which have their own unique features. But for now, the three big companies are Eloquence, Wolf, and Joymax. We use Eloquence system at UF.
Right, thank you. And there is a question, can we share the presentations from tonight's webinar? I think it depends on the permission of the presenters. So Azra Payne, which is hosting and supporting this event together with the APPD, we'll get back to the audience, once the presenters agree. So I'm very optimistic that we can share the excellent presentations we had tonight. Again, folks, any questions to the panelists? If that's not the case, then I think I would like to thank everyone for joining us tonight. And on behalf of Azra Payne and the APPD, again, APPD, that's the Association of Pain Program Directors, I would like to thank you for your participation in tonight's event. The next Azra Pain Medicine APPD Hot Topics webinar will focus on intrathecal pumps, indication, approach, and outcomes. And this webinar will be held on Tuesday, April 5th. Again, April 5th, please mark it on your calendar, 7 p.m. Eastern Standard Time. We hope to see you then. Thank you very much and have a pleasant evening.
Thank you. Good night.
Thank you.
Good night.
Folks.